last presentation. It will be by my colleague, Dr. Ahmed El Saeed, a lecturer of nephrology, Mansoura School of Medicine. Please welcome Dr. Ahmed.
It's my pleasure to be with you today, and this is the last presentation in our day. I hope it will be one light presentation. I will try to be focused on some important points about the focal segmental glomerulosclerosis in pregnancy. So my agenda for today will include the epidemiology of focal segmental in pregnancy, the focal segmental, how to differentiate from preeclampsia in some simple points, mostly are clinical points, the indications for renal biopsy in cases with focal segmental or primary glomerular disease in pregnancy, the maternal and fetal outcome for patients who got pregnant with primary glomerular disease or present with primary glomerular disease, especially the focal segmental during pregnancy, and finally, the management and our experience in Mansoura University. First, about the epidemiology. As you all know that the studies about the primary glomerular disease in pregnancy and focal segmental especially are a little number of patients and a small number of cohorts. So according to this one study, which followed the patient from 1997 to 2012, over 15 years, from 21 hospitals, studied the cases, and they have followed 173 pregnant-related biopsy, and they found that the focal segmental represented about 1/3 of the cases who had biopsy during or just after the pregnancy within 6 months, and about 1/3 or about 30% of these focal segmental cases were Black race, and the most common pattern was the not otherwise specified, about 60 to 70%. So the next topic or the next item, how to differentiate the focal segmental from preeclampsia. As one of our colleagues asked now, maybe the focal segmental is a secondary one, or it's caused by the preeclampsia itself. Actually, I will not go into this debate, but I will try to suggest some evidence that may help in the diagnosis for the shortage of the time. If the patient is presented before 20 weeks of gestation with proteinuria, so this is mostly a primary glomerular disease, or which is focal segmental, one of them, which represents 30% of the cases according to the studies. So it's one of the important ones to keep in mind. If this proteinuria persists more than 12 weeks after delivery, mostly it's due to the primary glomerular disease, not preeclampsia. However, some studies have showed that some patients with proteinuria may persist more than 6 months, but these are few cases and few studies, but mostly they resolve within 12 weeks. If the patient is presented after 20 weeks of gestation, this may be focal segmental or primary glomerular disease if not associated with hypertension, and if the patient is presented with active urinary sediment like hematuria and RBC's casts. According to the American College of Obstetrician and Gynecologists, the preeclampsia is diagnosed if there is a new onset of hypertension more than or equal 140/90 on 2 separate occasions after 20 weeks of gestation, or if the patient presented with blood pressure more than or equal 160/110, with the presence of proteinuria more than 300, or if the proteinuria is absent and the patient is presented with new onset hypertension and one of the following, such as thrombocytopenia, platelet lower than 100, renal impairment, creatinine more than 1.1, impaired liver function, pulmonary edema, or cerebral or visual symptoms. In the presence of hypertension, even in absence of proteinuria, preeclampsia can be diagnosed at this time if more than 20 weeks of gestation. So the new onset hypertension is the most important According to this study, one of the important biomarkers or the biomarkers that are important for glomerular dysfunction in preeclampsia. This meta-analysis included 12 studies, and they showed that the specificity and sensitivity for the podocyturia and nephrinuria, which are one of the marker or two markers of the podocyte damage, are highly sensitive and highly specific in cases of preeclampsia. However, there is an important point here. There is not enough data now to differentiate or use these markers to differentiate between the preeclampsia and the primary glomerular disease. They just have high sensitivity and specificity with preeclampsia, and they may also be present in some glomerular disease, but we can't use them to differentiate till now. Also, we can use some important ultrasound and Doppler, such as if we have abnormal placental appearance, or abnormal uterine artery Doppler examination, abnormal umbilical artery Doppler, this may suggest the presence of preeclampsia more than primary glomerular disease. One of the promising markers, according to the different studies now, is the soluble FMS like tyrosine 1 and the placental growth factors, which are factors produced by the placenta and represent dysfunction of the placenta. So if we have abnormal ratio of this factor or these markers, this may be a promising one for the diagnosis of preeclampsia with high specificity and sensitivity, and also correlate with the disease severity as well. So to the next point in our topic, what are the indications to do a renal biopsy for the patient? As we all know that it may carry some hazards for the patients during pregnancy. One of the important indications is the de novo nephrotic syndrome or nephrotic range proteinuria, or unexplained decline of GFR, especially before 20 weeks of gestation. Also, if we have situations prior to 30-week gestation where the biopsy may change the treatment decision, may add immune suppression, or may allow the use of plasmapheresis, as if the patient has rapid decline or AKI with active sediment, patient have rapid GFR decline in patient with known primary glomerulonephritis or primary glomerular disease, in some lupus nephritis cases with increasing proteinuria and declining of GFR, also in renal transplant with deteriorating GFR. So this may indicate a renal biopsy in patient with pregnancy. I know that some studies have shown hazards during pregnancy, but actually many studies also showed that these hazards are low and in very few patients, not in large number of patients. The next item of our topic is the maternal and fetal outcome in patients who got pregnant with focal segmental glomerulosclerosis, or who got focal segmental glomerulosclerosis during pregnancy. According to this study, which was done in patients with focal segmental glomerulosclerosis and reviewed several studies over 1980 to 2017, and this patient had biopsy-proven focal segmental glomerulosclerosis. When they followed the maternal and fetal outcome of these patients using this series of studies, as you see here, we have different studies done, about 12 studies or 13 studies done over these years, and these the studies which included the focal segmental glomerulosclerosis. As we can see, the different outcomes were the abortion, preterm delivery, small for gestational age, neonatal death, hypertension during gestation, and the proteinuria during gestation follow-up. Over these studies, the review showed that the abortion was 5.9 to 28 over these different studies. The preterm delivery happened in 6% to 58%. As for small for gestational age, many studies didn't follow this point and didn't show an answer. So according to the largest study of them, which contained 14 patients, the small for gestational age was 16%. For the neonatal deaths, we have 11% to 45%. For the hypertension, we have 20% to 70% of the patient who have increased or uncontrolled hypertension during gestation. The most important factor for the bad or the poor prognosis or poor outcome was the baseline level of proteinuria, as well as hypertension and CKD stage on diagnosis, and if the patient had poor uncontrolled blood pressure and proteinuria during the pregnancy. And finally, to come to this point, which I think one of the important points in our topic, what about the management for the focal segmental with pregnancy? Actually, the management would not start after the patient got pregnant, especially if the patient is known before pregnancy. We have many patients who have already focal segmental or primary glomerulosclerosis, and they want to get pregnant. So this patient should be followed before pregnancy. They should be advised about the type of contraception to use if they are not still fit for pregnancy, and what is the appropriate timing to get pregnant, when to get pregnant, and how to control the blood pressure. If they are fit enough to get pregnant, we have to change or stop the teratogenic medications, such as the ACE inhibitors, the mycophenolate mofetil should be stopped, and change it to another type or another drug that carry no teratogenicity for the fetus, and explain the complication well to the mother and her husband before starting to get pregnant. During pregnancy, we have to keep a target blood pressure lower than 140/90, starting low dose aspirin, vitamin D or vitamin D and calcium. Follow the baseline creatinine, proteinuria, and all over the pregnancy, we should also follow the creatinine, proteinuria, and the serum albumin. Monitor the calcineurin level if the patient is still taking cyclosporin or tacrolimus or any calcineurin. Anticipate, or we have to also follow for the glucose tolerance test or the thrombosis to avoid this complication during the pregnancy. One of the important points is the time of the follow-up of the patient and the visits for the patient to keep the patient under good supervision. On delivery, we have to keep an eye over the fetus and the mother. We have to give a corticosteroid to allow for the fetal lung maturation at least 24 hours before delivery. And if possible, for vaginal delivery. If not, we can go for cesarean. Postnatal, encourage the breastfeeding, especially if not contraindicated according to the immune suppressive drugs or the drugs that is used by the patient after the delivery. One of the important points, what are the drugs we can use for the management of our patient? For the hypertension, one of the most safe, as you know, is the methyl dopa. We can also use the labetalol, nifedipine, hydralazine. Amlodipine is used in some countries in Europe, but we don't have enough safety data. Avoid the use, or the use of RAS inhibitors is contraindicated during pregnancy. Avoid their use, and also for thiazide, better not to be used. If the patient is overloaded, furosemide can be used, but you have to keep an eye over the volume status for the patient and also the volume of the amniotic fluid. This should be followed in a good manner to avoid oligohydramnios. Also, the patient can be given low dose aspirin or low molecular weight heparin. Calcium and vitamin D can be also used. For the immune suppressive drugs, steroid can be used. Calcineurin inhibitors, which are the most commonly used for patients with focal segmental after the steroid. also can be used during pregnancy. They are category C, and if the patient is on them before pregnancy, they can be continued. For the azathioprine, it's category D. However, it can be used during pregnancy. This is an important question, how it could be a category D and be used during pregnancy. Actually, for the azathioprine, it crosses the placenta, but it's not metabolized. It's not metabolized by the fetal liver, or the fetal liver is not mature enough to metabolize the azathioprine, so it can be given because its metabolite can't cause an effect on the fetus. For the plasmapheresis can be used, rituximab can be used in early pregnancy, but no long-term safety data after early pregnancy or in late pregnancy. According to our experience, we have a good experience about follow-up of pregnant females. It's a good time to tell you about this experience. Actually, this experience started in 2015 when we decided to do or perform a follow-up study on the patients who are presented to us or referred to us from the obstetric unit for follow-up. Actually, this patient were referred to us in late pregnancy with AKI or renal complications. So when we followed these patients, we found that their outcome was not a good one. The maternal mortality was high, 22%, with multi-organ failure about 27%. Fetal outcome, intrauterine fetal this was 45%, and 15% had preterm, and the renal outcome, 37% had no good recovery of the kidney, and 35% needed dialysis. So after this study, we decided to do a good follow-up of our patient. So we decided to initiate and start and establish this unit, which is the Mansoura Obstetric Nephrology Service. We had this clinic where we can follow every patient who have a renal disease and decided to get pregnant, or any patient who is referred to us from gynecology and obstetric unit to be followed during her pregnancy, all over her pregnancy in this unit. So we divided the patient into low risk patient, medium to high risk, and very high risk patient. For low risk patient, they have a bi-monthly visit. For medium to high risk, they had 1 to 2 weekly visit. For very high risk patient, they may be admitted to the maternal care unit till they have a good follow-up and a good prognosis, so they can after this, or they pass the condition, so they can be discharged after this. After we established this unit, we again started to use this data or the data. As you can see here, the first column, which showed 0 maternal mortality and 0 fetal mortality and 3% only progression to end-stage renal disease. This is the column which represents the patient who were followed in our maternal unit or in our obstetric nephrology unit. The patient with the yellow column who showed 11% maternal mortality, 50% fetal mortality, and 13% end-stage renal disease. These are the patients who were not followed and were just detected in their late stage when they were referred to us after they had acute kidney injury or renal disease. And the last column with the gray, this was the result, the previous result of the study, which was carried in 2015. So as compared, we have very good results when we compare our results now after the good follow-up of the patient as compared to the previous results, and also as compared to the patient who didn't have a good follow-up. And finally, thank you. This is the picture which we want to see and which we want every patient to have, and to say congratulations on your good pregnancy and good fetus. And finally, thank you.
Thank you very much, Ahmed. You throw some lights on a major problem on how to differentiate a proteinuric patient during pregnancy. It's a daily practice. Actually, you are confronted with many cases like that presented by Dalia, and at the time we are in dilemma: is it primary glomerular disease or it is eclampsia or preeclampsia? And thanks for presenting our experience with the obstetric nephrology collaboration in Mansoura. Dr. Abdullah, do you have any comments on Ahmed's presentation before taking one or two questions from the audience?
No, I would like to congratulate you on these results from your unit. It's impressive. It does highlight the importance of having people who think about these patients all the time, taking care of them. They're very difficult to manage. It's very important to highlight the amount of fetal and maternal mortality that you were experiencing before. That's very important part of the counseling of these patients. A targeted and specialized care does lead to very impressive results. It's very impressive what you presented there as far as your division is doing. Congratulations.
Thank you very much. Mamdouh, do we have? I think we have one or two questions from our colleagues, the attendee. Can you present them, please?
Yes, we have one question here. What is the safe antiproteinuric drug during a pregnancy?
Ahmed, would you like to answer?
Okay, as for the safe antiproteinuric we can use during pregnancy, actually the data are not large for this, but according to some studies, the verapamil in short-acting form can be used, but the best is to control the blood pressure during the pregnancy. This is very important. And if you want to use, we can use the short-acting verapamil according to some small studies, but actually it's not large data.
As you said, Ahmed, the ACE and ARBs are absolutely contraindicated during pregnancy because of their teratogenic effect. So the use of non-dihydropyridines, L-type calcium channel blocker. And there is actually a growing data about the use of T-type calcium channel blocker, the lercandiben. It has antiproteinuric effect more than the L-type. So, thank you, Dr. Ahmed. I think